Welcome to Module 1B, where we'll be focusing on emergent situations, rapid response protocols, and the critical aspects of codes in the healthcare setting. My name is Jessica Granger, and today we're going to explore the roles and responsibilities that come into play during a rapid response or code, as well as the essential skills and knowledge needed to manage these high-stress situations. So, the role of rapid response teams. Rapid response teams, or sometimes often referred to as RRTs, are designed to intervene early when a patient's condition begins to deteriorate, with the goal of preventing further decline or cardiac arrest. For example, if a patient shows signs of respiratory distress, the RRT can be activated to provide immediate care, potentially averting a full-blown emergency. These teams are multidisciplinary, typically including a critical care nurse, respiratory therapist, and physicians, or advanced practice providers, all of whom bring their expertise to the bedside. The success of an RRT hinges on quick, accurate decision-making and effective teamwork, ensuring that the patient receives the right care at the right time. Communication during emergent situations is crucial, not only among healthcare team, but also within the patient's family. Clear, concise communication ensures that everyone involved understands what's happening and what their roles are. For instance, during a rapid response, it is important to keep the family informed about what is being done and why, which can help to alleviate some of the anxiety. Managing emotions is another key aspect. Families may be scared, they may be angry, they might even be confused. And it's our job as nurses to address these emotions while maintaining a very calm and professional demeanor. Remember that often the healthcare providers set the tone. So if you are acting upset and frazzled and stressed out, the family and the patient is going to feel the same way. But it's okay to feel those on the inside, but you need to check your emotions at the door, and what you project needs to come off as calm and in control. Okay? As nurses, we often serve as the bridge between the family and the rest of the healthcare team. So communication that flows smoothly between us and everyone around us is the goal, and it is of the utmost priority. So cardiopulmonary arrests can be triggered by a variety of causes, each requiring a different approach to the management. So a myocardial infarction, also known as a heart attack, we also sometimes refer to it as an MI, is one of the most common causes of your heart stopping, obviously, where the heart muscle is damaged due to a lack of blood. Respiratory failure, whether it's from a chronic condition like COPD or an acute issue like anaphylaxis, can lead to a cardiac arrest as the body is deprived of oxygen. Pulmonary embolisms, which are blockages in one of the pulmonary arteries, can also cause sudden cardiac arrest. Severe arrhythmias such as VFib or ventricular fibrillation or asystole disrupt the heart's normal electrical conduction and rhythm and can quickly lead to a loss of cardiac function. Another reason for your heart stopping could also be due to hypovolemia, whether that is extreme dehydration or blood loss in like a traumatic event. Understanding these causes can help all of us as nurses act quickly and effectively during a code. So the basis of cardiopulmonary resuscitation, or CPR, the basics are foundational skills that every nurse must master. It's important that every healthcare provider master these as well. The current guidelines emphasize a compressions-first approach for lay people, meaning that high-quality chest compressions are prioritized to maintain circulation until advanced cardiac care can be provided. In the hospital setting, though, you're going to do regular BLS. We typically teach lay people like compressions. If nothing else, just do compressions, because that has the best indicator when you're comparing compressions versus ventilations. Like just pumping on that chest for as long as you can has better outcomes than when lay people don't know what to do. They stop too often to give rescue breaths or check pulses. And so often we're teaching lay people just do compressions. So don't get confused with that. You are now an advanced care provider. So we're going to be focusing on the BLS into the ACLS, okay? So the recommended compression rate is 100 to 120 compressions per minute with a depth of at least 2 inches in adults. And that will ensure that the heart is effectively pumping enough blood with oxygen to get to all the vital organs, okay? Airway management, including the use of the bag valve mask or endotracheal intubation, is also crucial for providing oxygen to the patient. Early defibrillation is another critical component because, particularly in the cases of like VFib and VTAC, the sooner the defibrillation occurs, the better the chances of restoring a normal heart rhythm. So the purpose of a defibrillator, there's some pictures on the screen. So I know the one that everybody thinks of is the AED because that's the most common if you've taken BLS. That's the picture on the left with the little mannequin. So the two pictures on the right are two different cardiac monitors / defibrillators. The one at the top is a life pack, and it is an old dinosaur, but you will still see those. That's a portable life pack. A lot of times ERs will have things like this. You can actually hang it on the end of a bed and travel with it and have the patient on the cardiac monitor. You can shock, you can do all that, you can pace. We'll go over all this later, don't worry about it. But anyways, that's a life pack. And then the one that's on the bottom right-hand corner, that's another defibrillator cardiac monitor. You often see ones like this on top of a code cart. I mean, you can see the one on the top, on top of a code cart as well, but these are typically in on the code cart. So what is a defibrillator? It is a life-saving device that delivers an electrical shock to the heart in an attempt to restore the normal rhythm. So electricity, trying to make the crazy electricity stop and start again normally. It's primarily used in cases of life-threatening arrhythmias like ventricular fibrillation or pulseless ventricular tachycardia. There are different types of defibrillators, including manual ones used by trained healthcare providers. Those are the two on like the right-hand side. And then there's the AEDs, like the one on the left, that can be used by lay people. Timing is crucial when using a defibrillator, okay? The sooner that you can get it on the patient, to the patient, and used after a cardiac arrest, the higher the likelihood of that patient having a successful resuscitation and achieving ROSC. If you don't know what ROSC is, go do the ACLS Module 1. For instance, each minute of a delay in defibrillation can reduce the chances of survival by about 10%. So that just highlights and emphasizes the importance of rapid action during a code and getting the defibrillator to the patient. So ambu bags. So there's a picture of an ambu bag right there at the top. I will tell you this right now. You should always know where an ambu bag is. If you are in the ICU or ER, PACU, basically, I think everywhere you need an ambu bag in every room. At the beginning of your shift, you better make sure that ambu bag is there because I guarantee if you don't check it and it's not there, you're going to need it. If it's there, you probably won't need it. That's just the way life works, okay? An ambu bag, or sometimes we also call it a bag valve mask, or you will also hear people say BVM, is an essential device for providing ventilation, which ventilation is the actual physical movement of air in and out of the body, okay? So when you hear the word ventilation, that's moving air in and out of the body. So an ambu bag provides ventilation to patients who are not breathing adequately or they're not breathing at all. So proper technique is key to ensuring that the patient receives the necessary oxygen without causing harm. This includes securing the airway with the appropriate head tilt chin lift maneuver or using airway adjuncts like an oral pharyngeal airway. Delivering effective breaths means ensuring that the chest rises fully with each ventilation. You should be able to see it rise and fall, indicating that the air is reaching the lungs and fully inflating and deflating the lungs. It's also super important to avoid hyperventilation, which is breathing too fast, which can increase intrathoracic pressure and reduce blood flow to the heart, ultimately worsening the patient's condition. So it's often recommended when you have two providers doing chest compressions and you do the, for adults it's 30 to 2. When they are intubated and you're in a critical care situation, your ACLS, it's basically you're going to squeeze that bag and provide a breath about every 6 to 8 seconds. Okay, so that's only about 10 a minute. We do not want to hyperventilate these guys. We want to keep them on the low end, okay? The other importance, if you look at the bottom right picture, that is the EC clamp. You see the left 3 fingers are making an E, grabbing that jawline. The C is around the mask, pushing in a downward pressure to make a good seal. So when you squeeze that bag, the air goes in and it doesn't leak around the cuffs around the mouth. Okay, so preparing laryngoscopes and endotracheal tubes is a critical step in the airway management during a code. This is often, if you will see physicians and advanced practice providers, anesthesia, whoever is in charge of airway on the code team, they're just going to call and tell you, they're just going to show up and they're going to say, hand me a Miller blah, blah, blah in a 7.5 ET. And you better know what that is. So you want to get familiar with it, okay? So ensuring that the equipment is functioning correctly and ready to use can make the difference between life and death in an emergency, okay? The proper sizing of an endotracheal tube is crucial to securing the airway without causing trauma. The role of the laryngoscope is also to visualize the vocal cords. That's the top parts, okay? The top metal pieces. And they do have disposable ones as well. And these, don't throw those away after they're used. They'll be all bloody, and a lot of times they're bloody and they have like secretions all over them. They go to sterile processing, they get cleaned and put back into code carts or anesthesia airway kits. So like, do not throw those away. You'll get in trouble. The role, so those blades are meant to push the tongue down and also visualize the vocal cords, okay? So it guides the placement of the tube as we place the tube down into the bronchus. So being prepared and familiar with the equipment allows the healthcare team to act swiftly and effectively, which will minimize those delays and improve the chance of survival. So the Miller blades are straight, and the Mac, so we'll call them Mac blades, or I don't know if anybody says Macintosh blades these days, but typically the Macintosh is for Mac blades for smaller children, and Mac blades are for adults, and smaller kids use the Millers, the straight ones, okay? But you might have, that is totally provider preference, and you will have them ask for different things, and you just have to be prepared to grab it. And sometimes if you don't know what it is, just hold it up, say, which one do you want? And they'll point, okay? I mean, it happens. So resuscitation medication. So there's a picture of one code cart meds. So a lot of your resuscitation meds are going to come in pre-filled syringes where you don't have to think about pulling up dosages and stuff like that. You literally just Lura lock, open up the box, Lura lock it attached to the IV, and you just push, okay? Now, pediatrics is different. You're going to have to measure those out, and there's a whole nother thing about that. But for adults, for the most part, it's kind of like single dose things, and it's great because it makes things easy, okay? So during resuscitation, several medications play a crucial role in stabilizing the patient's condition. Each of these medications has a specific indication, mechanism of action, making it essential for nurses to understand when and how to use them effectively. Over the next few slides, I'm going to go over some of the big items for each of these meds that are listed on this page, but it's very important that you guys look up each of these meds on your own and you become familiar with them, okay? These are not all the meds that you're going to learn in this course, but let's get started with these. Now, at the bottom, it says Professor Granger's approach to learning medications, the med check method. We're about to talk about something that's a little on the side note, but here we go. Okay, so what is the med check method? This is me. This is specific to me. I have always loved meds. If you know my background, I was a pharmacy tech before I went to nursing school, so I've always been interested in medications. I feel like it's a forte of mine. When I have clinical groups, I will come around and I love to ask questions about meds, because what meds your patient is on will basically tell you the whole story. What meds have been ordered? Like, why was that med ordered? Well, I can figure out why they're there, what they're treating on, and what the plan is if you tell me the meds. I know a lot about what's going on if I know the list of meds the patient's been taking and what's the dosage and that kind of stuff. I know a lot. So to know how to safely give a med, when I have students, these are the 3 different areas, 3 different main questions I'm going to ask you about, okay, so that I know it's safe for you to give that med. And this, in my mind, students always are like, it's so hard learning meds. There's so much to do. You open up a med book and there's like 5,000 side effects. And I mean, it goes on for pages. Like, I hear it all the time. Like, what do we need to know? And you'll hear professors say the bold things, but that's still a lot. Okay. I'm going to tell you, start with this. Start with this on this page and start and do this. I don't care if it's meds for this class, behavioral health, whatever. If you can talk about this, what I'm about to go over any med, you can pretty much safely give that med to anybody. And you can probably answer any question that's going to ever be thrown your way on the NCLEX. So what does the med check method stand for? So the M stands for monitor before. So the question is what do I need to check or monitor before I administer this med? And it includes several things. So like right dose, right patient, all those rights. There's so many of them. Okay, so all the rights. Is that all right? Yeah, I mean, that's kind of a given. Like we're always going to make sure that it's the right dose, the right indication, the right. Okay, we're gonna make sure like no allergies, right? Like no allergies. But here's a big one: lab values and vital signs. Why do I need to check these? Now, do I need to check them on everything? No. Like if I'm gonna give Tylenol, do I really need to check a blood pressure? No. But do I need to check a pain level? Yes, that's part of vital signs, right? So example, let's say Lasix. It's a very good furosemide. It's a very good example. So before I give furosemide, okay, what do I need to check? Think about it for a second. How do I know it's safe to give Lasix? Okay, so think about what Lasix does, right? And like, what am I going to check just to make sure? Real quick, I'm going to like open up the chart, or I might be checking something on my patient. I might be getting a set of vital signs or doing an assessment, or I'll be checking. I need to check just to make sure that everything's okay. So what is it that you are going to check before you give Lasix? So if you answered in your head, you would check blood pressure. I would probably agree with you, right? Okay. So blood pressure is one of those things. Why? Why do I need to check blood pressure? Well, what does Lasix do, right? It's going to get rid of that excess fluid. So it's going to cause more urine to come out. So the pressure is probably going to go down. So I want to make sure the blood pressure is like at a normal level. If the blood pressure is 80/40, am I going to give Lasix? No, because their blood pressure is going to go down even more. I'm going to hold it, right? So I want to make sure it's at least normal so that I have some wiggle room. So if the blood pressure drops a little, we're still okay, right? So what lab values am I going to check? Think about it. What lab is affected by Lasix? If you said potassium, you are brilliant and good for you. And I'm clapping. That's clapping. Okay. So remember that Lasix furosemide is a loop diuretic, right? Okay, so it's going to get rid of that excess fluid and causing increased urine production, right? But what is it going to do to the potassium? The potassium is going to be excreted, okay? So it can cause hypokalemia. So if my potassium is 3.3, am I going to give Lasix? No. Gonna hold it. Call the doctor. Be like, hey. Now we probably can just give potassium to kind of like counteract that so that it doesn't drop. But like we need to address it. So like before I give it. So to answer the M, what do I need to check before? I need to make sure all the rights are there. There's no allergies. I mean, those are like give me like duh, right? And then I need to make sure the blood pressure is okay. And I need to make sure that the potassium is okay, because the potassium is going to drop and the blood pressure is going to drop. Okay. I know that. Okay, great. So now the E and the D are kind of thinking about after you administer it. So E is you're going to evaluate the effectiveness. Before you give this medication, you're going to think to yourself, after I give this, how am I going to know? How would I know that this med is working as intended? And I want this in simple words, simple speak, as I like to say. Like, we're not going to use medical terminology. We're not going to use fancy words. We're going to describe it as if you were describing it to a 10-year-old. You are standing in a doorway, looking at the patient. How would you know it's working? How would you know it's working? So if somebody says, oh, they have a Foley, and I just see all this urine go into the Foley. Yes, the Foley is going to go like shoosh, full of urine because we're excreting more urine. You might also know it's working because your patient is complaining that they're getting up to go to the bathroom every 10 minutes, or that they need a urinal and that they feel like they have to go a whole lot. Okay, so that's how I know it's working, right? So if somebody has like congestive heart failure and they have fluid overload and they're having difficulty breathing and stuff, well, if after I give Lasix, you might see them just kind of more relaxed and not breathing so heavily and so hard. That's another way that standing in the doorway, looking at the patient, I know it's working. Okay. So now the last question you're going to ask yourself before you give the med is, okay, So when I give this med to this patient, what am I going to look for? What am I going to be on the lookout for, right? To know that something went wrong. Like, this is going to be like a warning. Like, if I see this happen, I need to like stop, drop, and figure something out, kind of thing, right? Not roll. Nobody wants to roll on a dirty hospital ground. Anyways, so what would I see? What would I hear? If some, so for Lasix, I mean, obviously, I would hopefully, okay, so if it's going to drop potassium in the heart work really close together, and potassium, like, your heart is super sensitive about potassium levels, and it likes to throw a fit when your potassium is out of whack, per se, either high or low. So your heart, you're going to maybe see EKG changes, and that would be like an adverse effect, right? For Lasix, again, you might see the patient become like a little sleepy, little lethargic, like maybe like a little change in level of consciousness. Because what if their blood pressure just dropped and now they're not perfusing their brain? Okay, these are rare. That's not going to happen, but I mean, it could. Probably the potassium more than anything. If you didn't check it and it was low, and then you gave Lasix. Okay, so that's how I study meds. I study it in the way that it's actually going to apply to the real world, so that the next time I go give Lasix, I know what to look for. And it's in simple people words, simple people speak kind of thing. It's just very easy to understand, because think about it. We don't sit there and question you. Like, you're never getting an NCLEX question saying, okay, what is the, well, maybe you will in pharmacology, but not in an actual nursing course. Like, after giving Lasix, what is a potential side effect? What is an expected outcome, or whatever the wording is, and you're going to say an increase in urinary production. That's never going to be it. It's going to be like, what did the patient say that, indicated that the med is working? And then your options are going to be like, I'm in no pain, or I've been going to the bathroom 300 times, that's your answer, right? So that we're always going to be asking you to apply those basic knowledge pieces, right, in the test questions. So if you study it with the application piece in it, then when you get the test, it's like, boom, there, moving on, going. But what I find that a lot of students do, you're memorizing it and you're stopping right at, like, Lasix causes an increase in urine production, moving on. You're not taking those couple of seconds to think, okay, well, what would that look like realistically? Okay, there'd be more Foley in the bag. They'd be going to the, they'd be asking for urinals. They'd be walking to the bathroom left and right, which could be a safety issue, technically. So, like, that's how, if you just take those few extra moments to study and, like, how do I translate this into, like, what it would really look like in real life, you take the time to do that while you're studying, the test is going to be a breeze. So this is my method, okay? So it's what do I need to check before I give the med to make sure it's safe? How would I know that the med is working? Like, standing in the doorway, looking at the patient, or like looking at the chart, or looking at the monitor, like I don't have x-ray vision kind of thing, but like, just like simplistically, like, how would I know it's working? And then also, what am I going to look out for? So if I see it, I know I have to, like, intervene, like, because some things are going wrong. And the only other thing I didn't talk about is that if there is a med with a reversal agent, you better know it. So, like, if something went wrong, like I gave too much morphine, or they had more, opioids in their system or something like that. And they become obtunded and lose their consciousness, and, like, they're not breathing adequately enough. Well, I know I can go get Narcan because I need to give them an Narcan, and then they'll hopefully wake up, right? For opioids. So those are kind of the things that you guys need to, this is my suggestion when you're studying meds, study it like this, and you are going to be golden. And so those just do it in this method, and I really think it will help you. Okay. Anyways, moving on. Okay. So epinephrine. So the next few slides, I have some information about each drug. Okay. And I did my own little mnemonics. Yeah, thank you very much, because this is how I visualize it in my brain, and I try to do my best. Okay. Epinephrine is adrenaline. Adrenaline is epinephrine. Epinephrine is synthetic, man-made adrenaline. Okay. So think about what is going to happen to your body if a bear is chasing you. I mean, I always use that analogy for Epi, but if a bear is chasing me, my eyes are going to get big and wide because I want to like see where I can escape. And my heart rate's going to run fast. I might sweat and I'm going to be running. See the little running man for the bear? That was my best thing. Okay. But a simple memory for what epinephrine does is epi is epic energy booster. Okay. So epinephrine is often the first medication given during a cardiac arrest because it's going to rapidly increase the heart rate and the blood pressure. A simple way, like I said, to remember it is that like E for energy booster, epi for epic, you can do it either way you want, okay? It's going to give the heart the energy it needs to start pumping again, okay? So it's like a battery pack charge. Okay, now you can start going again. Yay! Okay, but it's also important to be aware that epi can cause significant tachycardia and hypertension, okay? So it could cause some other issues, and it can sometimes lead to dangerous arrhythmias, okay? While there are a few contraindications in the emergency setting, we're not going to focus on those in this course because those are kind of rare. The effects need to be closely monitored to prevent potential complications. So really, if somebody is coded, you're going to give them epi unless some really random weird situation and the physician tells you not to, and then you better ask why. We pretty much are always going to give epi if somebody's heart has stopped, okay? So now, amiodarone, okay? So it's an antiarrhythmic for VFib and VTAC, and the way that I remember this is amio slow, okay? And I don't know, I've named the snail in my head. That's Amio the snail. Okay, so amiodarone actually, if you want to get fancy with it, it slows the action potential of the cell. So it's like slowing the electrical conductivity of the cell, and it causes like the electricity, it can't go fast. And so if the electricity can't go fast through the heart cells, then it can't pump fast, if that makes sense. Okay, so it slows the heart rate down. So amiodarone is a powerful antiarrhythmic medication used primarily to treat VFib and VTAC. When those don't respond to defibrillation, okay? It's often like the second med given in codes for VFib, VTAC, but sometimes people forget to say, oh, have we given amiodarone? You will hear that a lot. And they're like, oh no, it's been 10 minutes and we should have already given this. Yes, you should have. So anyways, think of amio slow because amiodarone slows down and stabilizes the heart rate, okay? It's helped to control the irregular rhythms. It's effective, but it does come with risks, including hypotension. Because if I'm slowing the heart down, right, when you slow how fast the thing pumps, the pump is pumping, the pressure in the tubes in the system is going to drop, right? Obviously, bradycardia could be a symptom because we're slowing the heart rate down. So we might give too much, who knows, and it slows the heart rate down where now it's not effectively pumping enough. And in the long term, it can cause pulmonary toxicity, okay? But in the interim, we'll figure that out later. We're going to give it. We got to save their life first. It's contraindicated in patients with severe sinus node dysfunction, and AV block without a pacemaker. Given these potential side effects, it's important for you to monitor the patient closely when administering it. I don't want to say it's benign, but if your patient's in VFib, VTAC, you probably are going in and out of it. You're probably going to give amiodarone without a second thought. Okay, so now atropine. So you say it atropine, but if you look at the word, it looks like pine trees. Okay, and this is the way that I remember it. Pine trees are tall and pointy, so they look like arrows pointing up. So I just think of like high fast rate. See, you like my little picture there? So I made like trees with arrows. I think it looks amazing. But anyways, okay, so pine trees, fast heart rate. Okay, so atropine, we give that to speed up the heart rate. Okay, so atropine is the go-to drug for bradycardia as it increases the heart rate by blocking the vagus nerve. A simple way to remember it is the pine tree thing that I just told you about, okay? Okay, but atropine can also cause side effects like dry mouth, blurred vision, urinary retention, okay, because it is an anticholinergic. I will tell you that in peds, the peds population, and it used to be like all the time when we would intubate people, like you're always worrying about airway and you don't want to have a whole lot of secretions like in the back of the throat and the mouth and stuff that could cause, like you could aspirate on them. They used to routinely give atropine before they sedated and paralyzed people to intubate them for like even routine things. And we don't do that so much anymore. But that used to be like the practice. So if you find a very experienced, wise old practitioner that has lots of wrinkles, they may ask for atropine before sedation, and you can question it. Just make sure that their heart rate's on the lower end of normal, because it's going to cause it to go fast, right? Okay. So anyways, so that's kind of atropine. Okay, so now let's talk about dopamine. Now, this is kind of going to date me, but people used to be like, that's dope. And this is how I remember it. Okay, dope as in like, that's cool, or that's, I don't know what y'all's terminology is this day, but you get the drift. Okay, so dopamine is used to support blood pressure and shock by increasing cardiac output and systemic vascular resistance. Okay, that's really fancy. Okay, basically, dopamine is the same drug that your brain produces to make you feel good and happy and all that kind of stuff. But because there's a blood-brain barrier, the man-made, your body-made dopamine kind of stays in the CNS. And the dopamine that we can give you in your body is synthetic that we give you. But chemically, they're like the same thing, but they kind of do two different things. But if you can kind of put them together, I think it makes sense that they do the same thing. So dopamine, the drug, works to pump up your heart rate and your blood vessels. Like, hey, you're doing a great job. Yay, you. Just like how you feel when something is dope. Haha, happy and excited and full of energy. This helps the body get the blood flow it needs during emergencies like shock or heart failure. Okay, so remember, that's dope to help you recall how dopamine boosts the heart in a critical care. I mean, it's just for me. I mean, that's how I think it works, but that's me. The major side effects include tachycardia and arrhythmias, so that the patient's heart rhythm must be carefully monitored. There are also risks of tissue damage if the medication extravagates. So like if it gets out into the tissues, it can cause necrosis. Okay. A lot of these vasoactive meds that work on your blood pressure, especially increasing them, if they get out into the tissues, they're going to cause necrosis, because they're going to cause vasoconstriction, which is going to limit the blood getting to that area, and the tissue is going to die. Okay, so we want to make sure that this is given in a central line, not like a little peripheral IV kind of thing. Okay, the major side effect includes tachycardia, arrhythmias. Already talked about that. So contraindications for this. So really, there aren't a lot. We pretty much give it no matter what. This is what your book says, but pheochromocytoma, that's really a tongue twister for me, and uncorrected tachyarrhythmias. So it says that those are contraindications, but I've very rarely not seen it given when it's indicated. Okay, so dobutamine. Do not mix this up with dopamine. Dobutamine and dopamine, they are different, okay? So dobutamine provides inotropic support, meaning it helps the heart pump more effectively by increasing cardiac output. So this is going to cause the squeeze to be stronger. Instead of like this little weak squeeze of the heart, it's going to be like, I'm such a strong pump now, okay? So dobutamine is like a personal cheerleader for your heart, saying, go heart, do better, squeeze harder, go heart. That was my cheerleader voice. Okay, so this drug helps the heart pump more effectively, improving blood flow and supporting the body during heart failure or other conditions where the heart needs a little extra help, okay? So the heart's being a little wimpy, and so we're going to give them some dobutamine, the do better heart, so you can squeeze better. Okay, so if I'm squeezing stronger and harder, can that cause my heart and my blood pressure to go up? Sure, okay? But this one can actually lead to hypotension, because like other inotropes, dobutamine can cause tachycardia and arrhythmias, which that is what would lead to hypotension. So remember, if your heart is beating super, super fast and it's not getting, and then the electrical conduction kind of goes a little wonky for an arrhythmia, okay, then it's not fully able to squeeze out everything effectively. And so then that would cause systemic hypotension. I hope that makes sense. It is contraindicated in patients with idiopathic hypertrophic subaortic stenosis. Say that 10 times fast. A condition where the medication can worsen the obstruction of blood flow to the heart. Honestly, you can memorize that, but that's not that important to know, okay? The others are more important. So, yay, dobutamine. Okay. So adenosine. Okay, so now you will hear people call this adenosine and adenosine. You will hear it both ways. Okay, which way is it to say? It's kind of like tomato, tomato. Okay, so adenosine, I always say adenosine, works like a big, bold stop sign. Okay, so when you look at the word, this is how I always remembered it back in the day. It looks like sign, S-I-N-E, like a stop sign. So I would say like it's a sign, like stop, slow down. Okay, proceed with caution and be slow. Stop running, kind of thing. So so think of it like a big stop sign, okay, signaling to stop and slow down when it's racing out of control. The medication is particularly useful in cases of supraventricular tachycardia. We call that SVT. You will hear people say SVT all the time. This is where the heart basically is like, I mean, a simplistic way of saying it is spazzing out. It's just squeezing and like really, 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 really fast. Okay. And when you beat really, 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 really fast, you're not able to fully get all the blood in and all the blood out of your chambers. And so then you're not perfusing and you will potentially like lack of oxygen to the brain, heart. And these people, like, they will feel like crazy anxiety and like pain and then like lightheadedness first. And a lot of times people with SVT that it's recurrent, they know that it's coming on, an episode is coming on, and it can be very anxiety producing and anxiety producing. You can be awake and alert with SVT, but it won't last forever, and eventually you will become not awake and alert, and your heart will eventually stop if you don't correct it. Okay. I will tell you, so this is the med to correct it. The other way that we treat it, and we'll go into this earlier, is by doing like a vagal maneuver. That can sometimes work. It doesn't work that great, but it sometimes works. But adenosine is basically, it's very scary when you give it, because you give it and what it does is it literally stops the heart for a split second. Like no electrical conductivity is allowed to go through it. So it's like, stop. Okay, now hopefully start again. So it's like turning off the power to your computer and praying that it turns back on again. When you push it through the IV, its half-life is very quick, okay? And it will either work within seconds or it won't. And you may have to give repeated doses, okay? And that's very common. And so when you give adenosine, you're going to watch the cardiac monitor and you're going to see like the SVT, the tachy wavelengths of the cardiac monitor is going to be like, and then all of a sudden you're going to like flatline, and then hopefully it starts back up like a doop, 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 and it doesn't immediately go back to doop, 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 doop. Okay, that happens too. But I mean, I would rather it go doop, 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 doop than never come back at all, because that does happen occasionally. That's not cool, and you just start compressions. Okay, but anyways, okay, back to the medication. You will have the brief asystole. That's what I was talking about. And then people can have like chest pain and flushing. Expect asystole, meaning no heartbeat for a couple seconds. Everybody holds their breath, and then it'll start beating again. And that's like, oh, yay. Yay. Okay. The most notable side effect is that brief period of asystole or flatline on the cardiac monitor. Okay. And like I said, it can be alarming, but it's expected. So expect it, and it typically resolves quickly. Other side effects include chest pain, flushing. Adenosine is contraindicated in patients with second or third degree AV blocks or sick sinus syndrome without a functioning pacemaker. Important, but I mean, if you're going to waste your time, I mean, not waste, sorry. If you're going to spend your time studying things, there's other things to study. The first three more than the contraindication. Okay, so Procainamide. Procainamide is an antiarrhythmic that's effective against both the atrial and the ventricular arrhythmias. Okay, so some only work on ventricles, and some, there's just different areas, but this one is on both of those. And remember its role. Procainamide, one of the ways you can remember is Procainamide is pro-rhythm. That is one way to do it, and it helps maintain a normal heart rhythm. Another way to think of it is think of Procainamide as a pro-electrician. So Procainamide is a pro at making sure the heart acts right, okay? So just like a skilled electrician who carefully manages electrical currents to prevent short circuits, Procainamide keeps the heart's electrical signals slow and steady. This helps prevent those dangerous, chaotic rhythms that can lead to serious problems. So when you think of Procainamide, remember it's the pro-electrician that keeps your heart's electricity from acting up. So some of the major side effects include hypotension, which can occur if the drug is administered too quickly. It's kind of a more, you don't want to do rapid push. And QT prolongation. Ask yourself what you know about EKGs, and if you prolong the QT interval, what happens? Think about it. Okay. So it's contraindicated in patients with complete heart block or torsades, and it can exacerbate those conditions. So if you don't know what torsades is, we're going to learn about it later. So vasopressin. Now, this was my attempt at vasopressin, that right-sided vessel on the screen. Forgive me. I attempted, okay? Vasopressin is used as a vasoconstrictor, because we're pressing on the vessels, to increase blood pressure in cases of shock, particularly when other medications have not been effective. You can think of it as pressing on the vessels, okay? So the tube is getting smaller, but there's the same amount of liquid in it, so the blood pressure goes up, okay? So the major side effect, obviously, it could be hypertension, but we're probably giving this because they were hypotensive, so, it's one of those things. And also it can cause ischemia due to reduced blood flow, water retention, and it can lead to hyponatremia. Again, ischemia, hypertension more than water retention I would worry about. Okay, so sodium bicarb, that's another med. This just kind of goes in and out of fashion too. So it's funny how meds become popular and then not, and then again, and then not. So sodium bicarb. You can think about this like baking soda for the blood. I mean, not that you would ever put baking soda in your blood, but just you can kind of think about it. Okay, so it's going to correct metabolic acidosis. So it's used in codes primarily to correct codes that are caused due to acidosis, a condition where blood becomes too acidic, obviously, which can occur in prolonged cardiac arrest or severe shock. So somebody has, for a very long time, had a lack of oxygen to tissues, okay? They are going to become acidotic. You can also become acidotic if you have been hypoventilating patients, and not blowing off that extra hydrogen ion. So an easy way to remember its function is bicarb is a balanced acid. That's one way of doing it, okay? Or it's baking soda for the blood. Okay, it works like, so the reason why I say the baking soda is it works like that, but it neutralizes acids in cooking. We all know baking soda neutralizes acids in cooking, okay? So like that, bicarb neutralizes the excess acid in the body that can build up during critical situations, okay? This helps restore balance, the pH levels, and prevents further complications. So pH levels are always a fun task to manage after a code or during shock, while somebody's going into a severe shock, and when people have been sick for a very, very long time, or ischemia to different areas of their body. So it's just part of the management strategy, okay? So it's important to be aware, though, that some of the side effects from bicarb might be something like causing the blood to become too alkaline, which could lead to alkalosis, the opposite of acidosis. Other risks include hypokalemia, where potassium levels drop, hypernatremia, where sodium levels increase. Sodium bicarb is contraindicated in patients who already are experiencing alkalosis or hypernatremia, as it could exacerbate those conditions. In a code, the decision to use sodium bicarb should be based on an arterial blood gas results and the specific clinical scenario. It's not just something we give to everybody. Ensuring that it's used appropriately to improve patient outcomes. So that's it, kind of overarching of meds. Now let's kind of get into roles and team members of the resuscitation team or the code team. Okay, there's a lot of roles. It's great if you have enough people for all of these. You don't often have it, but these are all the roles that could be there. I will tell you those first three, those are the most important. So team leader directs resuscitation efforts, makes the decisions. That's typically going to be your physician and or advanced practice provider, but it could be the nurse. Airway manager, this person on the airway, ensures the airway is open and patent, and they will perform intubation. So you might start off as airway, and then when RT or anesthesia shows up to the code, they're going to take over. The compressor, I think that's pretty obvious. They're performing high quality chest compressions the whole time, and hopefully there's multiple people so that y'all can take turns. Then there's the IV or IO access nurse. This is the person that's going to get access. This is more for your ER situation, but you might need an extra line if you're going to be doing some of these vasoactive drugs and you don't have a central line in a patient. We need to put a central line in, not that we're putting those in, but you'll be helping people set up for that, or maybe potentially like looking for a larger bore, a larger vein to put a large bore IV in. You just never know. So then there's the defibrillator operator. So it's very rare that one person just does that, but they manage the life pack. The recorder, the person that gets to document, they get to stand there and write everything down. And you better be good at paying attention and listening, because you've got to write the times for everything, what everybody's doing, and it's all happening simultaneously. Medications nurse obviously prepares and administers meds. If you're not great at math and you are in a pediatric area, probably something that you should work on and get better, but this is probably not the best role for you. You need to be able to calculate things real quick sometimes, okay? For adults, it's not that bad, okay? The runner, this is typically going to be if you have unlicensed assistant personnel like a tech, PCA or something. It's typically a runner, but students could easily be runners, and other nurses could be runners. Sometimes everybody ends up as a runner because you're all running around. You're going to go get other supplies. Somebody's like, I need a central line kit, or we don't have tubing for suction. Okay, that stuff happens. Okay. Family liaison. Sometimes you have like an advocate there. Sometimes you don't. Depends on your facility and who has a pager for the code team. Respiratory therapist. Pretty standard in the ICU, not so standard in the ER. But if you're at more of a teaching facility, you're going to probably have respiratory there. But they're probably going to come from somewhere upstairs, but it may be a hot second before they reach you. Chaplain. I love it when the chaplains are on the campus and respond to codes. They are very, very helpful, especially with the family. And often your house supervisor is going to show up. They're going to be there because if a code is happening, they may have to be the one doing the paperwork. There's places where the house supervisor can actually be the person to call time of death if there's not an advanced practice provider there. That's advanced training, but a nurse can do that in some cases. The house supervisor also, if the patient has to be transferred out somewhere, they're going to be working on that, getting them to another facility with a higher level of care. The house supervisors they show up a lot of times during codes. They don't always show up, but they do a lot, especially at night. So family presence during cardiac arrest. If you've already watched the ACLS Module 1, we talked about this extensively. So I'm not going to go into massive details on this. You can read this, but it's very important to have the family's presence during cardiac arrest, okay? There's lots of benefits. There are some negatives that could happen, but you got to balance out both of them, okay? There's ethical considerations, and you always want to go by policy, but also you want to do what's right for your patient and also right for the family, okay? So just take that into consideration. Then on the end, so let's just do a little brief review. So in conclusion, this whole great, beautiful 1A module, we've covered the critical aspects of emergent responses, rapid response teams, and codes in the healthcare setting. We've discussed the roles and responsibilities of the resuscitation team, the importance of effective communication, ethical considerations of the family presence during cardiac arrest. As nurses, our role in these situations is so, so, so important. And it's important that we also are prepared both in our knowledge of our roles, the medications, and everything like that, and our skills, okay? I encourage each of you to take the time to practice the skills that we discussed, especially your CPR skills, or at least refresh your memory on those skills, okay? What you remember from airway management, you're going to have a skills lab where you're going to get to go and see all of these the first lab of this year is the critical care environment. You're going to be looking at the code card. You're going to be looking at intubation, ET tubes, meds and things. And you may have had codes in previous semesters, but I really want you to become familiar with the equipment we have in the sim lab. Ask questions about it, ask how it's used in real life, those kind of things. Okay. It's really important for you guys to get familiar and to keep your skills up no matter what. You're just students now, but you're going to be nurses very, very soon. You're going to get to have RN at the end of your name. That's exciting, right? Okay. So, I want to thank you all for your attention and the time that you took to listen to this. Okay. I look forward to seeing you guys in lecture, and I will talk to you guys later.